Welcome to the Population Project presented by Misty Dominguez for Nursing 541. First, we must identify our at-risk population. Who are we talking about? In this community, we're talking about the elderly persons with dementia who run into residential crisis due to a lack of community education and resources. What we find is law enforcement presents the affected individuals to the emergency department for assistance, and oftentimes this leads to unwarranted hospitalization due to sudden notable decline in the ability for the patients to care for themselves, a lack of adequate caregiver options, and little to no funding arranged for residential care. This poor community educational resource assists with proactive planning causes hospital impact issues. The national level population impact is significant. More than 5 million Americans over the age of 65 are suffering from dementia. And by 2050, the number of people aged 65 or older with Alzheimer's disease or other dementias may nearly triple, with a projected population of 13.8 million people. In 2015, 15.9 million family and friends provided 18.1 billion hours of unpaid care to those with dementias. That care has an estimated economic value of $221 billion. We also find that more than 15 million people are providing care to loved ones with dementia. Of those caregivers, 34% are women over age 65. And 60% of those caregivers rate their stress as very, very high. 74% report they have concerns about maintaining their own health or have reported neglecting their own health in order to fulfill their caregiver roles. 41% also have a household income of less than $50,000 per year. The state impact of dementia is also significant. There are 588,000 Californians aged 55 or older living with dementia. 1/10 of the nation's Alzheimer's population resides in California. Anticipating by 2030, we will see this number double, and our dementia population in California will be 1.1 million people. 1 in 6 Californians will also develop a dementia. We have 1.1 million Californian caregivers that are caring for people suffering dementia. Those caregivers provide 952 million hours of unpaid care per year with an economic value of just over $10 billion. And by 2030, there is anticipated 69% increase in the dementia population in California. What is our local impact? Kern County has a total population of 880,000 people, and of those, 10% are over the age of 65. Of that 10%, another 10% has a diagnosis of dementia. That equates to over 2,000 Kern County residents that will eventually require care for advancing dementias. And unfortunately, another issue Kern County faces that's different from the rest of the nation is that we have a very high rate of poverty. Approximately 25% of all residents in Kern County are at or below the federal poverty line. A significant social determinant of health is that poverty is linked to lower educational levels, and poverty also equates to less available resources to impact care needs. So what does this mean for Kern County, and how do we compare to state and the national populations? As far as the prevalence of dementia, Kern County equates to the national and state levels. The disparity we find is that the rate of poverty is 35% worse than in this community than at the California level. And poverty is a significant social determinant of health, and that increased rate of poverty impacts options and decisions. Many of our elderly are not able to think about pre-planning, but just about getting by day to day, thus leaving them vulnerable as the disease like dementia advances. So how do we set up the framework for change? For this particular project, I think the Catholic Health Association model is the most appropriate. It is designed for hospital staff who conduct and oversee community health needs assessments and planning community benefit programs, as well as focused on collaboration, building on existing community resources, and the using public health data to secure its position. In this community, we have 8,800 elderly people with dementia. Over 2,000 have an income below the federal poverty level. And by 2030, this number is expected to double. We also have a lack of community resources available. We have poor education, very poor advanced care planning, and we have crisis-driven interventions in place at this time. 3, appropriate community health diagnosis to support the proposed intervention is ineffective role performance secondary to impaired cognition. This is supported by the community assessment data presented previously that details the barriers to good care and the barriers that caregivers have related to self-care. This is in alignment with Healthy People 2020, the overarching goals as related to social determinants of health. We want to attain high-quality, longer lives free of preventable disease, disability, injury, and premature death. The community needs assessment highlights the need for safe, effective relocation and housing options when living independently is no longer an option, or when caregivers can no longer manage the needs of those demented in this community. The community needs a guide also notes financial options that need to be able to fund placement and or arrange for payees to be responsible for managing the financial obligations of those that can no longer handle the responsibilities themselves. The individuals needs supervised care that can ensure safety when the affected can no longer protect themselves environmentally. Lastly, medication supervision is needed to ensure compliance and safe dosing in order to control other chronic conditions that may need to be managed. The second community health diagnosis is ineffective health management secondary to impaired functional ability. Again, the community diagnosis aligns with Healthy People 2020 and the overarching goals of achieving health equality, eliminating disparities, and improving the health of all groups. The community need prioritization is education both to providers and the public so as to start proactive social management of the social sequelae that dementia brings. Last community health diagnosis would be compromised family coping secondary to a lack of social support. Again, this community health diagnosis aligns with the Healthy People 2020 social and physical environmental goals. The community needs based on assessment are accessible community resources like education, support groups, and the awareness of community residential options. Additionally, teaching the community what needs to be in place prior to crisis so placement can occur in a well thought out and planned way is necessary. So what interventions are proposed? The interventions are twofold. First is an educational campaign. This is a primary prevention initiative designed to fill high-level programmatic gaps in resources to educate. Also, this educational campaign should be aimed at working with the community agencies and primary care providers to create a safety net of awareness that can act as a preventative measure to protect those at risk. It is also proven that early intervention can positively affect outcomes of individuals with dementia. The second half of the proposed intervention is crisis placement. This intervention will be a hospital-driven initiative to funnel those individuals that present to the emergency departments in residential crisis due to functional decline from dementia into safe, secure housing on a short-term basis while long-term solutions can be arranged. This would be a secondary level prevention initiative. This intervention is supported so as to preserve hospital resources for those that are truly in need of them rather than tying up an acute care bed with a social placement issue. Also, this solution is cost-effective for the hospital, allowing the hospital to mitigate losses and use financial resources to proactively impact the community. Some considerations that must be taken into place related to the interventions is that first, with the educational campaign, in order to be successful, dementia resource education partnerships with community agencies must be firmly established, and the partnering agencies must have the available resources to devote to the success of the project. Secondly, to launch a crisis placement option, funding and hospital administrative support must be firmly in place. Again, the community agency partnerships must be firmly arranged, and those agencies or vendors must be ready to perform and commit to completing the work necessary to ensure next steps on the road to long-term placement. Is the community ready? First, to ensure the community readiness for an intervention, we must confirm need. And in this case, the community is ready for this intervention, as evidenced by the large volumes of calls the hospitals receive from community members asking for help. The proven lack of resources that are available to manage crisis situations are obvious, and frequent ED visits solely for caregiver breakdown prove the need. The ongoing discussion had with other hospital administrators reinforced that this is a community-wide issue and just not a specific hospital issue. To have success, it is essential certain key stakeholders are in support of these projects. From this project, hospital administrators, ED providers, health plan administrators, community agency leaders, and program vendor participants must be on board and willing to provide the support and backing necessary to find success. The logic model works well for this particular project. When considering inputs, or the things that we invest, the hospital is investing time, labor resources, and capital backing for the lease agreement. Our activities and things that we do to make the project successful would be collaboration between partnering agencies, development of community education curriculum, assistance with community educational campaigns, and emergent short-term placement to hospital-supported housing with intensive transition of care case management. Our outputs, or who we will reach, will be people affected by dementia in Kern County and their caregivers. We will touch those that are in residential crisis due to the effects of dementia. Our outcomes and or changes that will occur is that the community and health providers will be aware of resources available to support the caregivers and patients impacted by dementia. The goal is to impact change enough that pre-planning is possible so as to lessen the frequency of crisis intervention needed by acute care hospitals. The result and the impact of the outputs and outcomes will be a better educated community, enhanced awareness with the goal of pre-planning for the advanced care needs of the dementia patient, and we will curtail financial losses suffered by the hospitals due to crisis management of dementia care. Moral and ethical contributions to the wellness of our community will also be met. How will we evaluate the success of the program? I think we'll use the structure, process, outcome model of evaluation. In the current healthcare environment, more emphasis is being placed on outcome evaluation. And this evaluation model holds true to that premise. Evaluating the structure of the program is focused on evaluation of the setting in which care or intervention is occurring. And in this case, that would be the outpatient setting. The process evaluation is focused on the effectiveness of the intervention and what is the teaching and is it effective? Were the alternative placement options successful? Outcome assessment would focus on the benefits experienced from the intervention. Are there less ED visits due to residential crisis? Is the hospital losing less money unnecessarily on social admissions due to dementia and caregiver breakdowns? Lastly is cost evaluation. What would be an effective choice in this situation, I believe, would be cost-benefit analysis. The reason being is that we can quantify the current losses the hospital is suffering. We also have a fixed cost for leased beds for residential crisis placement. If we note a decrease in non-reimbursed hospitalization, that will tell us our savings and also determine our return on investment. This is as a quantifiable number. Our call to action. As healthcare providers working in a safety net hospital serving Kern County, we have a responsibility to provide services and help to link those that are vulnerable with their necessary resources. We must also proactively educate our public and provide guidance to them to prevent epidemic situations. By acting now and initiating a twofold campaign to educate and provide crisis intervention for those with dementia that can't help themselves, we are acting as community stewards. We will enhance awareness, promote proactive and prevention, provide a safety net when all else fails, and protect valuable hospital resources that are limited in our community. Together, we can impact positive change. In summary, the issue is Kern County has an issue with fragmented care of the elderly dementia patients. This has led to increased ED presentation and unwarranted acute admissions. The impact has been poor community awareness of resources, inappropriate resource usage, and revenue loss. The action would be educational campaigns focused on proactive care planning and early intervention, crisis placement options to prevent unwarranted hospitalization, and the improvement we can expect is community awareness, community resource linkage, crisis prevention, and decreased inappropriate ED usage. Lastly would be revenue savings from the hospital. With all of these together, we can impact change.